Everyone, happy Thursday. I hope everyone is enjoying the beautiful weather. I know I am for sure. Does anyone have any quick announcements before we get started? I don't want to take too much time away. All right, so let's get into it. So today we have Dr. Nikhil Ahuja talking about his research on smoking cessation among low-income pregnant women and about tobacco-related disparities among low-income population in general. Like I mentioned, I don't want to take any time away from his presentation, so I will let him introduce himself and take it away.
Hi, thank you, Katrina. So as he mentioned, my name is Dr. Nikhil Ahuja, and I'm currently working as an assistant professor in the Department of Public Health at Slippery Rock University of Pennsylvania. And so I started working as a faculty in fall 2021 last year, and before that, I finished my uh, doctoral degree from University of Memphis School of Public Health. Uh, and I've been working in tobacco control since like more than 7 years now. And I have a background in dentistry, and I try to kind of, relate oral health and, tobacco cessation programs. And I published and presented at various national and international conferences, specifically focused on oral health and tobacco control topics. So yeah, I think it'll be interesting to kind of share one of my research projects which we did while I was in Memphis and working on smoking cessation among low-income pregnant women. So should I just share my slides, Katrina? Okay.
Yes, that's perfectly fine. Is there an option to request it?
Okay. So just let me know if you're able to see it.
Looks good.
Great. Okay. Okay. So I think this is one of the project, as I mentioned, which we did while I was working with some of the faculty members at University of Memphis School of Public Health, and it was a project which we kind of worked on. So it's about smoking cessation among pregnant and postpartum women from low income groups in the United States. So So before I start, this study is already published in the Journal of Midwifery and Women's Health. And, you know, uh, I would like to thank, my co-authors, who have kind of worked really hard in terms of making sure that this study was completed and, make sure that, it is published and we can disseminate now findings to different stakeholders, who can really help us support in terms of designing interventions and programs for this particular population. So before I start, I just want to give you a background, to kind of help you all understand how is the smoking, behavior, especially among, pregnant women and postpartum women. So although in terms of tobacco control, we have seen that, there is a decline in smoking rates overall, but we still see that, there are a lot of, tobacco related disparities, particularly among certain groups, which is really, creating a problem. And one of the group which is affected is the pregnant woman. And I think it's a public health concern in the United States. And there's a data, which suggests that, 1 in 14 women who gave birth in the US reported smoking during pregnancy. So one of the concerns, which I have been seeing with the data in pregnant women is that there is an underreport, and a lot of research have suggested that. And this is because there's a lot of stigma in terms of reporting smoking behaviors, especially among this particular population, and that's why some of the numbers you will see that there is underreporting, although in reality there might be more smoking use among this particular population. And we really see, there is like a disparities in smoking rates during pregnancy in different population groups. Like for example, the data suggested that women 20 to 24 years of age, like there is 10.7% of smoking rates. If you think about race, we see that non-Hispanic American Indian or Alaska Native origin 16.7%, non-Hispanic white origin 10.5%. And when we think about different socioeconomic status, people belonging or pregnant women from lower socioeconomic groups, especially those who haven't completed their high school, there is a high prevalence of smoking in this population, that is 14.1%. This is, I picked up, recently one of the studies which was published in 2020, and we really see that, the disparities are like consistent in different population groups. And if we see by race, as I mentioned before as well, we see the highest smoking rates in pregnancies among American Indian or Alaska Native population, followed by, the whites and the black, and the lowest rates we see in Asian Pacific Islander group. So that's the disparity which is consistently we are seeing from 2010 to 2017. That's the data suggested. When we think about education, uh, we see that the same trends kind of exist. We see that people who haven't completed their high school diploma, they are like at a higher risk of smoking, and followed by people who are less than 12 years of school education or some college, and people who have completed higher degrees like bachelor's degree, master's degree or higher, they are at they smoke less as compared to the other groups. So we are really are seeing these disparities related to different social determinants, specifically related to race and education and income groups. So there is a lot of research, in terms of understanding the negative impact, how smoking can affect, maternal and child health. And I just wanted to highlight, some of the things why it's really important to understand tobacco use behaviors in this particular population, because we see that, a lot of women have to deal with, miscarriages, placental disruption, stillbirths, sudden infant death syndrome, a lot of respiratory infections, ear infection, chest infections in the early childhood for the children, and a lot of other, behavioral disorders, as children like, go into their adulthood, if women continue to smoke, in front of their child, and that's the kind of impact, we see of smoking on this particular population. So, once we have this understanding, about how smoking kind of affects this particular group, we really need to understand about how the smoking cessation is kind of affecting, this particular group. And we have seen that, a lot of studies have shown that the women who quit during pregnancy compared to who do not quit, who those who quit are from high income groups, are they kind of perceive more risk related to smoking, as well as they are highly educated. And the data suggests that approximately 45% of women stop smoking before their first antenatal visit. Once they realize that they're pregnant, that kind of motivates them to quit smoking. 72% stop smoking between the first and second trimester. That's the data which really suggests. But we have seen that despite, there are a lot of interventions currently available or the programs available, we see that more than 60% who stop smoking during pregnancy, but they kind of relapse, within 6 months, once they deliver their child. And the relapse rates are as high as 43%. So that is kind of concerning. All the women might be quitting during their pregnancy or just before their pregnancy, but once they deliver the child, they relapse within 6 months. So that's the reason we need that. The data indicates that we need ongoing cessation support even post pregnancy. So that's the data which kind of indicated once we started understanding this particular topic. So since we wanted to understand different barriers and facilitators, we really went deep into the literature to understand, what are the different factors basically affecting this underserved groups or low income population. And we really found out, that there were specific social and economic barriers which the pregnant women from low income groups are facing. And one of them was financial insecurity, insufficient housing, perception, stress, and boredom. These were like, some of the determinants which kind of played an important role in smoking cessation. There were dependence, there was fear of weight gain, non-adherence to smoking cessation services, and that was also related to some of the social determinants, which they were facing in their life. There was insufficient support from healthcare providers, and it's important to remember that most of these studies try to understand individual behaviors in different studies. So what our aim was to kind of look in a comprehensive manner, how smoking cessation, what are the different barriers and facilitators are affecting this particular group. And we adopted a socio-ecological framework. And when we think about this particular framework, it really helps us in understanding, the multiple level factors which are affecting this particular population. And the socio-ecological framework is divided into different levels. At individual level, we wanted to understand, whether there are any barriers related to knowledge, attitudes, and behaviors which are kind of affecting this particular group in smoking cessation. What are the different interpersonal factors, whether there's a role of, families, partners, or maybe social networks, how that kind of affect this particular population. Are there any factors related to community, maybe social norms or organizational factors in terms of, getting cessation support from different organizations? Or at the policy level, are there any policy level factors like, for example, state laws, federal laws, how they are kind of, how does the woman basically think about this particular laws? So we really wanted to take a comprehensive approach in terms of understanding smoking cessation among this low income population. So how we decided that we should take this study, because there was a systematic review which we kind of reviewed before taking up the study, and there were 15 studies which were focused on understanding barriers and facilitators, but there were only 4 studies which focused on pregnant women from low income groups. And we tried of then try to relate this particular thing which with the data which we had in terms of statistics, and we that what kind of motivated us to focus more on this low income population. So our study kind of basically provides theoretically informed insights into different barriers and facilitators among pregnant and postpartum women from low income groups in the US. So that was kind of the basis how we kind of thought about working on this particular study. So this was a qualitative study which was conducted at the WIC offices and a public hospital in a large mid-south metropolis of the United States. And the inclusion criteria, since it was focused on pregnant and postpartum women, so we kind of only included women who smoked at least 10 cigarettes a day, 1 month to getting pregnant. They were like into 24 to 34 weeks, 32 weeks of pregnancy, or within 12 weeks of giving birth at the time of interview. Our focus, as I said, was on low income backgrounds. So we only included women who had like families below 150% of poverty level. So that's how we kind of, selected our population, and who spoke English. So that was kind of, our inclusion criteria in terms of selecting our population. It was a semi-structured interviews which we conducted using an interview guide, and an interview guide wherein the questions was focused more on understanding what are the different factors affecting this particular population in smoking cessation. These interviews were conducted with 60 women who agreed to participate in this study, and each interview was conducted with 2 women and 1 man. So we had like a mix of 3 interviewers. The interview lasted for 60 to 90 minutes with each woman. We used deduce qualitative software to kind of analyze this data using a directed content analysis approach. And this approach is more about identifying different themes based on certain framework. And since we used socio-ecological framework, so we tried to, analyze our findings, based on this particular framework, like how different teams were organized at the individual level, at the interpersonal level, at the organization, and at the policy level. So the study protocol was, approved by the Institutional Review Board at the University of Memphis and the University of Tennessee Health Science Center. So in terms of demographics, uh, so I hope you're able to see. I know it's kind of a busy slide, but then I'll just go through, certain demographics. So we wanted to have a balance of demographics, how we selected the 60 women. So as you see, there were like, 53% of whites and 47% of African American women in our study. Uh, Marital status, we saw that 65% were single, never married, 25% married or living with a partner. In terms of education, there was a balanced profile in terms of who were in less than high school. There were 45%. Most, like 73.3%, were unemployed in terms of, so that's kind of indicates, the disparity in terms of income. Household income, we see that majority of them were like around 43%, had a family income of 20,000 to 30,000. In terms of pregnancy status, there were 68% who were pregnant women included in this study, and there were like 35% who were postpartum women. So we kind of wanted to have a balanced view of understanding, what are the barriers in the postpartum woman as well as in the pregnant woman. Smoking status, 41.7% were current smokers, 20% had stopped smoking since pregnancy, and around 38% tried to stop but relapsed. So that was, kind of the demographic which we saw in our study. So results, I think that was something which was really, exciting for us to understand. So as I said, we classified different themes at different levels of, so because we wanted to really understand what are the factors affecting at each level. So let's, beginning with at the individual level, we saw that there were 6 important factors, which kind of uh, related to the barriers and facilitators among this low-income pregnant women in terms of smoking cessation. And there was only one facilitator, like which motivated this pregnant woman to smoke, and that was a theme related to perceived risk of smoking. And I think majority of the women we interviewed, they said that, they wanted to quit smoking as soon as they knew that, they were pregnant. So that was something which majority of them told us. And and one of the things which was also mentioned by these women was like they really were concerned about their baby's health. So that was, a motivating factor. And that's why we always, say that pregnancy is a time, which we really need to target in terms of making sure that women quit smoking, because that's where, they are concerned not only about their own health, but also the health of their baby. And one of the quote, which is mentioned here is like since I found that I was pregnant, I cut down on a lot. I'm wanting to, I don't want this baby to be sick or nothing or anything wrong with it. So that was a quote, we had from one of the women. The other thing which I wanted to mention is that there were other women who kind of also talked about not complete cessation, but slowing down on cigarette smoking. So which is a harm reduction approach. And there were different, perceptions these women had. They were like, since they didn't had any issue with their first pregnancy and they continued to smoke, so therefore they wanted to just, continue to smoke for the second child as well. So there were other women as well, talking about this particular stuff. And there were some women who were concerned about, exposure, second-hand exposure to the baby's health. So they told us, even though they are smoking, they won't smoke in front of their child. They would just go out and smoke, and so that they are not exposing their children to, the smokes. So that was, there were, different women had their own perception. So that was, how we classified this facilitator into the theme of perceived risk of smoking. The barriers, when we talk about barriers, one of the barriers which comes up always in smoking literature is the addiction and habit. So most of the pregnant women said that they had this cravings, and there were a lot of issues. Pregnancy also creates a lot of pressure. There is a lot of emotional thing involved in terms of getting pregnant and how to deal with certain situations. And they were so addicted. There was so much craving. They really wanted something which kind of relieved their stress. And that also kind of related well to the other barrier which we had, like coping with stress and bad nerves. And there were a lot of women who kind of talked about they were into habit of taking a cigarette early in the morning, before they just got up, and they really wanted cigarette. So that was a habit they went into, which kind of made it difficult for them to quit smoking. And there was a lot of going on in terms of managing the children, or there was issues related to their issues with their spouses, or they were concerned about their parents' health. They were concerned about financial issues, housing issues, and these were low income women. And that kind of created a lot of stress in this particular population. And that's why they kind of, it was difficult for them to quit smoking. As one of the quote which I've mentioned here is, in terms of stress, is like, uh, the woman talked that the child makes her really nervous, because I'm always watching what she's doing. That what makes me smoke, because I'm so nervous and stressed, and that's why it's hard for me to quit smoking. So these were some of the emotional quotes which came out while we were interviewing this pregnant woman. And stress was one of the important factors. And in tobacco research, we have seen that definitely when someone is dealing with this bad nerves or stress, emotional stress, or financial stress, or stress related to different social determinants, they are more likely to smoke, and less likely to quit smoking. The other thing which came up in this particular population was dealing with boredom. And we see that as I said, in the demographics, that most of the women were unemployed, so they really didn't have anything to do at home, and that kind of made them get indulged in smoking behaviors. And there was one of the participant who also said that, like driving a car, sometimes they're just sitting in a car, they're bored, and that's why they want to just have a cigarette in their hand, and they just want to make sure that they deal with this boredom. And if they also mentioned that they're sitting at home, they really don't have nothing to do. They're just dealing with the pregnancy, and they don't have support from their partners. And that kind of, makes them more indulgent in smoking, and they're less likely to quit smoking. So that was, one of the things which came up. There was a fear of weight gain as well, as we all know that that is something, how the tobacco industry kind of markets these products to kind of make sure that women continue to get indulged in this smoking habit. And there was fear that once they quit smoking, they're going to gain weight, and they were so dependent and addicted to smoking that they thought that once they quit smoking, they're going to eat a lot of food which will kind of make them overweight or obese, and they were concerned about that, and that's the reason they continued their smoking behaviors. And finally, there was lack of willpower and determination in terms of quitting smoking. That also came up from the majority of women. So these were some of the factors which were really important at the individual level to kind of we found out. So definitely interventions which will be designed based on these particular factors will be crucial. One of the things which was striking was at the interpersonal level, and that was support from partner, family members, and others in the social network. And there were majority of women who said that since they had their partner who were smoking in front of them, and even though they had quit smoking, that was kind of really difficult. It made really difficult for them to quit smoking. So I mean, one of the quote, as I had mentioned here, is the woman said that being in a household that my husband smokes or whatever, that's going to be even harder for me to quit being around. So that's why I said, that support from the partner, and maybe it kind of interacts with the relationships they might have with their partner, and that kind of creating a lot of stress for this particular woman to quit smoking. And they also, majority of them talked about, even though they had quit smoking during pregnancy, so once they were done with the pregnancy and there were a lot of family members visiting and sometimes their brothers visiting or other family members, so sometimes they would just light up cigarette in front of them. And so that kind of, discourage them, in terms of their quitting behavior, and they would just relapse and go back again to their normal smoking behavior. So I had this one of the quote, I had smoked for 2 weeks, I didn't have any cigarettes, my brother came over with his cigarettes and I got one of his, I went from there. So that's how, the relapse. So that's why, it's really important to make sure that we are having the ongoing sedation support even post pregnancy, because that's where, most of the relapse occurs, and which is as high as, 43%, as I mentioned. So women really talked about, they really need an environment wherein they get support. No one is smoking around them, or maybe, having a support group, for example. Nowadays we have this online cessation support, and they were really not aware about these, different resources which are currently available. And I think in terms of, thinking about interventions, it will be really important to kind of make sure how we involve these low income, women in these particular support groups, which would kind of help them in smoking cessation. So that was, about at the interpersonal level, which we found out in terms of support from partners, family members, and others in the social network. So at the organizational level, we came up with a theme of nicotine replacement therapy and counseling. And that was like many of the women, talked about. And there were a mixed findings, which we really found. There were some women who kind of had used these NRT therapies, or, patches, the gums and the inhalers. And there were some women who didn't knew that, even these NRT therapies kind of exist. So that was something, surprising in terms of uh, that what kind of work we need to do in terms of creating awareness about these particular, medications which are available in this particular population. So one of the quote which I have is like, the woman said that I quit smoking for 2.5 months using, Zyban. Then I ran out of the prescription and didn't have money to go back. So that was one of the factors. So the cost factor which came up among this low income woman in terms of buying these medications. So something to think about, we as public health professionals, like how can we make sure that, we have easy access and reduce the barrier related to cost for this particular population, so that they can have access to these medications, to the counseling services, like at the individual counseling, the group counseling, or maybe the telephonic counseling. And women also said that, they had never tried patch, never tried gum, nothing. But if they are given these counseling services, or they are being provided with this, patches, they would really stop smoking. So that was kind of encouraging, in terms of the findings which we had. And so I think going forward, it would be really important to make sure that we make these medications and counseling services, accessible to this low income woman, and making sure that we and we already have this in the Medicaid programs, but it varies with different states. Like for example, Tennessee, where this study was conducted, it kind of varies how the nicotine patches and the counseling services are provided under Medicaid programs. But when it comes to Pennsylvania, we see that, pregnant women get access to these medications. And there are also, concerns in terms of, cost sharing, as some of the women need to share cost in terms of, the deductibles, the co-pays, the co-insurance, and all those stuff, which kind of really creates a barrier for them to access these particular medications, and which kind of, again, makes it difficult for them to quit smoking. So we really need to think about, these particular factors, when we design our interventions for smoking cessation. At the policy level, most of the women were supportive of how the taxation policy we have in terms of tobacco control, like the cost, basically, since these were low income women. And so they told us that, these cigarettes are expensive, and you pay like $5 for a pack of cigarettes, and that will kind of, have them buy a gallon of milk for the baby. So it's really important that we continue to, tax these products, tobacco products, because that would kind of, discourage smoking behaviors among this particular woman, and low income women who, and that's the strategy. Even WHO, like FCTC, Framework Convention of Tobacco Control, really promotes, because we really need to make sure that states tax cigarettes well, so that the young population, or even people who are from low income backgrounds, making it unaffordable for them to buy these cigarettes. And most of the women in this particular study were also supportive of this policy. Even the warning labels on the cigarette packs, many of the women supported that, like some of the warnings they had, some of the pictures, which was available on the cigarette packages, that kind of also made them think about their baby's health. And this we can really relate well to the individual level, the perceived risk of smoking. So there are a lot of studies which have shown that health warnings kind of increases the risk perception, which kind of again motivates people to quit smoking. So it's really important to continue to make sure that we have these warnings on the cigarette packages. And so these were some of the things at the policy level which we found out. So thinking about these different factors, what I have discussed here at the individual level, at interpersonal level, at organization, and at the policy level, it's really important to integrate, I would say, smoking cessation and relapse prevention support into maternal and child health services, including the breastfeeding services, because it's really important that the gynecologist or the obstetricians, they kind of promote smoking cessation. Healthcare professionals are aware that what kind of strategies they need to use, maybe the 5 A's and the 5R techniques, which are generally being used by different counselors and health professionals to kind of motivate quitting. And as I discussed, stress came up as one of the major factor which majority of women kind of talked about. So it's really important to incorporate these stress management techniques, into prenatal care, because most of the women are kind of suffering from stress, and they're dealing with a lot of emotional issues and a lot of financial issues, which kind of creates a lot of stress. And different stress management programs have shown that if we incorporate them in low income women groups, it kind of reduces anxiety, depression, and the stress. And we really need to think about the social determinants. How are we addressing that? And that can be dealt with, promoting more of social safety net programs, like making sure that this low income woman, uh, we reduce the poverty, we make sure that the housing is accessible, we make sure that they are provided with affordable housing services, we reduce the financial insecurities, and and that will kind of improve their physical, psychological, and economical well-being, especially among this population. So we really need to think about, as a whole, how we can make sure that we promote smoking cessation, especially among this particular group. Then weight gain definitely came up, as I said, as one of the factors. So we really need to think about, maybe enhancing or maybe integrating, healthy eating and promoting physical activity as well. Along with, we really cannot isolate, physical activity, healthy eating services from smoking cessation, since it's kind of related. So we really need to make sure how we integrate, different programs related to healthy eating or physical activity behavior and smoking cessation together, so that these particular women are not concerned about quitting smoking. There are existing partner focused interventions which are currently available that kind of promotes, but the effects have been small. So I think going forward, what I have noticed is that we really need to think about what are the dynamics of relationships. Like, even if we are promoting partner focused interventions, what kind of dynamics the women kind of share with their partners, with their family members, and all those stuff. So making sure that there is good relationships, wherein there is supportive and trustworthy relationships with their partners, with their family members, that would kind of play an important role in promoting smoking cessation. So there were limitations, it was a purposive sampling, which limits the generalizability, but definitely comparing with the barriers and facilitators we have in the literature, this study also kind of provides the similar findings, which most of the women kind of face, especially from the low income backgrounds. And it was recruited from Memphis And so we really cannot, apply findings to other geographic regions. For example, PA might have different policies, or in terms of Medicaid programs, as I mentioned, and also the women are different, in terms of how they would perceive smoking cessation, what could be the different interpersonal factors and different regions. So it's really important that we broaden the sample and explore further in terms of barriers and facilitators in specific states, to kind of more get into deeper understanding of how these barriers may differ in different geographical regions. And adopting this socio-ecological framework definitely helps us in taking this comprehensive approach in understanding smoking cessation among this low income women. So, so there are a lot of barriers and facilitators which we have discussed, and it's really important for healthcare professionals, especially midwives and obstetricians, to kind of be prepared and use latest evidence-based treatment, because there are a lot of other research which have done that even healthcare providers sometimes have insufficient evidence, and they kind of fear about teratogenicity in terms of recommending NRT therapies. They're really concerned. But if you go through the United States Preventive Task Force document, we can really make sure that we make use of these 5 A's and 5 R's techniques to kind of promote smoking cessation among this particular population. And it's really important thing to promote cognitive behavioral therapies first, since these are like pregnant women. And if someone is really nicotine dependent, and the recommendation is then to go for this NRT therapies, but it really needs to be recommended or advised under professional help. So that is something which even the literature says. So it's important to build trust and supportive relationships. The providers need to really ask women at their first antenatal visit, and continue to follow up, what is the smoking behaviors among these women, even once they have uh, you know completed their pregnancy checkup. So that way, we can make sure that there is complete cessation which we can achieve in this particular population. So I think that's all I had about this particular presentation today. I just want to thank the co-authors which who helped us in conducting the study. The study was supported by a research grant from the Urban Child Institute in Memphis, Tennessee. So would like to thank them as well in terms of making sure that we finish or complete this project. So thank you, everyone. So I think if you all have any questions, or I think I can take that right now. Yeah, thank you.
Perfect. Thank you so much. Does anyone have any questions?